Hi, so today we are talking about approaching the emergency patient in the emergency room. We'll be discussing the three major body systems and how to assess for perfusion, hypoxemia, localization of lesions within the respiratory tree, assessment of neurological function, and then different neuroprotective strategies that we can use. So when an emergency patient first comes into the emergency room, there can be a lot of noise, a lot of mayhem, a lot of blood. And what this talk aims to do is to direct and focus that initial assessment and treatment of these patients and not be blinded by what's obvious. It allows triage of multiple patients at a time so we can focus on the sickest. Now, these are probably things we already do, but having a systematic approach will help with the tough cases. So the reason I'm passionate about this is we did a lot of teaching at the University of Melbourne for vet students and even new grads. And one example I think of is an old husky that I was helping a new grad manage. This was an older husky, was wheeled in by the nurses, covered in blood on its face, was poorly responsive. Now the nurses were worried about that blood. They placed a catheter, they got a blood sample for a radiometer panel. They were asking about doing a blood transfusion or blood typing. How much fluids does the patient need? I think the new grad was a bit overwhelmed. So I said, let's start with our major body systems. And within minutes, we decided that, yeah, the dog definitely had signs of hypoperfusion. But actually, there was an arrhythmia that we could hear and pulse deficits that we could feel. And so very quickly we decided that, the dog perhaps fell down or collapsed from a syncopal episode and maybe bit its tongue, and that's why there was lots of blood. And all that blood could wait, but the atrial fibrillation couldn't. So the major body systems assessment is what's taught at the emergency room at University of Melbourne. It's a rapid assessment of function of the major body systems, focuses that triage and where to do the initial stabilization. It's kind of like that primary survey that we use. Now, it's not completely diagnostic and not a complete physical exam. So in 2018, Ash et al. Published a paper looking at predicting mortality using the animal trauma and triage score. So that's parameters of perfusion, cardiac, respiratory, eye muscle integument, skeletal, and neurological dysfunction. They found that it was a great predictor for mortality in injured dogs. What they also found, though, was that just using 3 parameters was just as good as a complete score. And this is what makes up the 3 major body systems. So in an emergency situation, these are the 3 systems that if they fail, they're going to kill your patient very quickly. These are the cardiovascular, respiratory, and neurological. So we're assessing for signs of perfusion, assessment of hypoxemia, and assessment of neurological dysfunction. Now, bear in mind that with the brain, this is quite a downstream organ system. So if there's failure in the heart or lungs, then we will see reductions in neurological function. So we need to look at that in context. So this is rapid. It's done in 2 to 3 minutes. It's not a complete physical exam, but it's to develop a prioritized problem list for stabilization. Then the rest of our physical exam comes afterwards. Now, just a quick note, we do see unresponsive patients that are potentially dead. We often start with our ABCs, or now prioritizing CAB, so circulation, airway, and breathing. But as per the Recover guidelines, if you are presented with a non-responsive patient that is apneic, it warrants the immediate commencement of cardiac compressions and running a code. But the rest of my talk is about patients that are alive. So let's start with the cardiovascular system. So what we are looking for in the cardiovascular system is signs of perfusion. Now, what is perfusion? Perfusion is blood being pumped to organs in order to deliver oxygen and other metabolic substrates to the tissues. and removal of byproducts of tissue metabolism. So to think of that, we use our tree of life that maintains perfusion in our patients. So there's a lot of different things going on here, but I always start with cardiac output because we know that that's made up of heart rate and rhythm and stroke volume. And that stroke volume is comprised of preload in the heart, contractility of the heart, and afterload. That cardiac output contributes systolic blood pressure to our mean arterial pressure. And that diastolic blood pressure comes from the systemic vascular resistance. And once we have blood pressure, we can have perfusion into the body. Now, perfusion isn't just blood going to the tissues, but we need oxygen. And delivery of oxygen is comprised of cardiac output and concentration of oxygen in the blood. And what makes up oxygen in the blood? It's the partial pressure of oxygen and concentration and saturation of hemoglobin. So in states of normal perfusion, the body thrives. But when we have hypoperfusion, which we call shock, there is global tissue perfusion failure. And so cellular oxygen delivery is impaired. When this happens, cells are forced to create energy under less than ideal circumstances, such as anaerobic conditions. But then there are also some compensatory mechanisms by the body in order to maintain perfusion. And so in early stages of shock, it can actually be difficult to appreciate that the patient is having hypoperfusion. And that's important because the major body system assessment looks at downstream evidence of hypoperfusion. So the tree of life is a good way to think of these compensatory mechanisms. So as some examples, in patients with hypovolemia or reduced preload, we have reductions in stroke volume, cardiac output, blood pressure, and so our perfusion fails. As a compensation, the body can increase the heart rate and increase the systemic vascular resistance to maintain that blood pressure. As another example, in vasodilatory shock, where there is decreased systemic vascular resistance due to vasoplegia and reduced perfusion, the heart rate can increase, but the stroke volume can also increase. Finally, in anemia, where there are reductions in hemoglobin and reduced delivery of oxygen, the body can compensate by increasing heart rate, increasing stroke volume, and increasing systemic vascular resistance as well. So to assess perfusion, we use 6 perfusion parameters. In states of shock, the heart rate increases in order to compensate for that hypoperfusion. The mucous membranes can change shades of red and become pale with vasoconstriction, or more red and injected with vasodilation, and even change color if there's abnormalities in oxygenation causing cyanosis, or changes in hemoglobin causing methemoglobinemia. Now with our refill time, in people it's actually a really important monitoring tool in patients with septic shock. It's an assessment of the microcirculation of the mucous membranes, and it can be brisk or prolonged. Now, when we feel pulses, we are feeling the difference between the systolic and diastolic pressure. What we want to feel is both the femoral and metatarsal pulses, and feel the height or amplitude, so that's how hard it pushes on your fingers, and the width of the pulses, so they're a lot narrower. If the pulses are absent, they are hypotensive. But if they're palpable, it doesn't rule out hypotension. Then 2 other more downstream signs of hypoperfusion is cool peripheries and reduced mentation. So always have a feel of the limbs. This is just a general guide of the signs of types of shock. As we said before, there are compensatory mechanisms in early or mild states, And so in mild hypovolemic shock, the heart rate can be high, but the CRT can be rapid to compensate by increasing stroke volume, and our pulses can also be a bit more hyperdynamic. Then as the severity increases, the parameters become more abnormal. Now in the vasodilatory phenotype of shock, the heart rate is usually much higher, our mucous membranes are red and injected, and the CRT is brisk, and the pulses are often bounding or hyperdynamic. Now, of course, cats like to make things a little bit more tricky. As a normal, their mucous membranes are usually a little bit more pale, and their pulses can be a bit more difficult to feel. And so subtle shock can be difficult to appreciate, and moderate shock is often missed. So, in emergency patients, or the cats, it should be on your radar and you should be looking for it. The increase in heart rate might not be as marked, and they can, of course, be bradycardic. Now, whilst discussing shock, we should talk about cardiogenic shock. This is when the pump mechanism of the heart is not working to push fluid or blood through the pipes or vessels. So this is forward flow failure of the heart. Often there's a concurrent murmur or arrhythmia, and usually there are signs of backward flow failure or congestion. So that's respiratory distress or ascites. So of course the treatment in cardiogenic shock is a bit different to the others. We don't want to give fluids, we want to treat the forward flow failure. However, bear in mind that most of the time, backward flow failure is usually more life-threatening, which we can see on our other major body systems. So that needs to be treated as a priority. So what if you're not sure? Is the patient in shock, or are they just painful, or are they anxious? There are a few other adjunctive tests that we can use to increase that index of suspicion. We can do a non-invasive blood pressure, but bear in mind this does not always equal perfusion. But if it's low and needs to be treated. If it's normal, then there may be some compensatory mechanisms keeping it normal. Lactate is a frequently used marker of hypoperfusion. So this increases in states of anaerobic metabolism, and is also a good marker of increased catecholamine during shock. In conjunction with lactate, we use acid base. So often our pH is low and our base excess is low. And so acidemia is more likely to be associated with shock. In people, improvement in venous oxygen, so that's from mixed venous from the pulmonary artery or central venous from the cranial vena cava, improvement in this can be used as endpoints for shock treatment. So remember that in states of shock, delivery of oxygen is reduced, but our consumption of oxygen at the tissue level remains the same. So it means that there's an increased oxygen extraction ratio, and so less oxygen makes it back to the heart and to those vessels that we are testing. So moving on to the respiratory system. We want to assess for hypoxemia, and then some localization within the respiratory tree. So, to maintain normal oxygen in the blood, we need to have normal ventilation, V, and perfusion, Q, to the lungs. So when we're discussing hypoxemia, we need to think about how oxygen makes its way from the outside into the bloodstream. So with normal ventilation, or V, air goes in with the breath, flows through down the upper respiratory tract, the lower respiratory tract, and then into the alveoli. Now remember, the lungs aren't just one big alveoli. There's about 600 million alveoli, some open better than others at different times. Then for global body oxygenation, we rely on perfusion, or Q, to the lungs. That perfusion allows the oxygen that's in the alveoli to get through the pneumocyte, the interstitium, the vascular endothelium, plasma, then into the red blood cells, and then into the hemoglobin. So there's a fair way for that oxygen to go. and then it circulates around the body. So with that in mind, there are 5 main causes of hypoxemia or low blood oxygen. So you can have reduced PiO2 or FiO2. So usually this is anesthesia, we forget to turn the oxygen on, or patients living at high altitudes. And these are usually responsive to oxygen therapy. There can be global hypoventilation, usually in neurological dysfunction or disease of the brain or lower motor neuron. They can respond to oxygen, but you often need to treat that hypoventilation and breathe for them. Now, VQ mismatching is what we most commonly see in the emergency room. So that's abnormalities in the alveoli, so fluid, cells, collapse or obstruction, and this does respond to oxygen. And that's a low VQ mismatch. You can get a high VQ with pulmonary thromboembolism. We can have anatomic shunts, shunting blood past the lungs, and this does not respond to oxygen. And there can be diffusion abnormalities, so thickening of the interstitium or the alveolar disease, and this does respond to oxygen. So, when performing your rapid assessment of hypoxemia in the patient, you always start with a distance exam, so take a step back. I always get a rate, and I would like people to give me a number. Tachypnea is regularly missed as panting. Now, panting is a normal physiological response of dogs to heat. And so they are panting very rapidly, the tongue's hanging out, it's often red and folded up. What I want to know is the respiratory rate 100 or is it 60? Because I don't want to ignore it, even if we think it might be normal. In terms of effort, usually the inspiratory phase is much shorter than the expiratory phase when we breathe. If you can appreciate a longer inspiratory phase, then that patient has an increased effort, or if they're showing signs of orthopnea or open mouth breathing. When assessing respiratory patterns, we actually look at the abdomen. So we're looking for paradoxical abdominal movement. This can be seen as an asynchronous pattern, so the abdomen goes in while the chest goes out, or an inverse pattern where the abdomen goes out and the chest goes in. These are abnormal. Mucous membranes, we've already done them with the other body system, but we're essentially looking for cyanosis. It's only evident when they're severely hypoxemic, so bear that in mind. Then we can have a listen, and I still start from a distance. We're trying to listen for pharyngeal stertor, laryngeal stridor, or expiratory grunts, then having an auscultation of the lungs to listen for increased, decreased lung sounds, or even crackles. Then if we're worried, give them oxygen straight away. Here are just some videos with some respiratory patterns. So in this dog, we can appreciate that there is a longer inspiratory phase and an inward asynchronous pattern of the abdomen. And the dog is open mouth breathing, not panting. In this cat, we can see that the chest is actually going in. So this is in, 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 in. And we know that because you can appreciate condensation on expiration at the front of the mouth. So in, out, in, out, in, out, in, out. So this cat has an inverse pattern. And here is a cat that sustained a trauma. And we can appreciate a flailed chest segment. So this segment of the chest goes inwards on inspiration. So there are a few other tests for hypoxemia. Often people use the SpO2. This is a great test in patients that are not moving as much, or anesthetized with their tongue hanging out, and not much movement to have a good tracing. In the emergency room, when their patient is fighting oxygen, fighting the catheter, it's difficult to get a good tracing and a reliable result. So often if I think they're hypoxemic due to my major body systems assessment, then they're probably hypoxemic. I'm not completely discounting the SpO2. It's obviously very good for subtle decision making if we perhaps want to try the patient out of oxygen later, but maybe not at the initial emergency assessment. PaO2 is obviously a far superior assessment of oxygen in the arteries, but it's also impractical in an emergency. The PCO2 can give us an idea of the work of breathing. So if it's low and the patient's hypocapnic, then it means there's an increased work to get that oxygen in. If it's high, that might be the cause for respiratory failure. So we've decided the patient's hypoxemic, we're giving oxygen, now what? We can try to localize the disease within the respiratory tree. So starting at the top, at the upper airways, we think of our brachycephalic obstructive airway dogs, or laryngeal paralysis dogs, or cats with laryngeal tumors. Often there's an inspiratory effort, an asynchronous pattern, but what you can hear is stertor or stridor. Initially, they need sedation to stabilize, and to diagnose that, we need to do an upper airway examination, and safely when we intubate them. Moving on, the lower respiratory tract, we think of our bronchitis cats. They often have an expiratory effort, an asynchronous pattern, and we can often hear inspiratory or expiratory grunts, and maybe even some fine crackles on auscultation. Initial stabilization is oxygen and potentially bronchodilators or steroids. We often need x-rays to diagnose. Now, pulmonary parenchymal disease is the one we most commonly see. So this is fluid, either cardiogenic, non-cardiogenic in the lungs, pneumonia, neoplasia, pulmonary thromboembolism, or contusions. Patients often have an increase in respiratory effort, an asynchronous pattern, and crackles in auscultation. And so we give them oxygen. And at this point, POCUS, or point of care ultrasound, can be a very handy tool to look for B lines. Then we can confirm later with X-ray once they're a bit more stable. Pleural space disease is either fluid, air, cells, or tissue within the pleural space. They have an increase in respiratory effort, and they can have an asynchronous or inverse pattern in cats. We can appreciate reduced or absent lung sounds, and they require oxygen for initial stabilization and a thoracentesis, which can be therapeutic and diagnostic. And POCUS is also a good tool in this case. Moving outwards, I think of the chest wall, the diaphragm, and the abdomen. So this is usually trauma, flail chest, paralysis, abdominal distension. We can have increased or reduced effort, an asynchronous or inverse pattern, and lung sounds are usually normal unless there's concurrent pulmonary parenchymal disease. And often they respond to oxygen. Sometimes they actually need ventilation, and we use X-ray to confirm. Then, of course, there can be our non-respiratory lookalikes, so severe metabolic acidosis, pain, anxiety, anemia, and even medications that we've started, such as opioids. Usually most parameters are normal, but they can have an increased rate and potentially an increased effort as well. So initial emergency diagnostics for stabilization and localization is usually our physical examination. So we do our major body systems and often looking at the upper airway if we need. The POCUS is a valuable tool in the emergency room for these cases. It helps you easily rule in or rule out pleural space disease or rule in severe pulmonary parenchymal disease. I really only get x-rays on these patients when they're much more stable. We should not need x-rays to make stabilization choices. And having said that, thoracentesis is a very viable both diagnostic and therapeutic tool if we suspect pleural space disease. There is nothing wrong with both a blind or a negative tap in these patients, because we would rather have a negative tap than leave a patient with pleural space disease that we can quickly relieve and stabilize. Now, of course, we've done these tests, and the severity of disease in the area that we localize is not as bad as a hypoxemia. Then maybe start afresh, go back, have a look at the rest of the respiratory tree again, starting from the top. So moving on to the brain, we are talking about assessment of brain function and the neuroprotective therapies that we could start. Once again, brain function is severely affected by the cardiovascular and respiratory body systems. And so in those cases, using these tools to trend neurological function is good. But we can actually have patients that have both that can have primary brain or spinal emergencies. So the modified Glasgow Coma scale was developed by Shores in 1983. It's based on the Glasgow Coma scale used in people, where lower scores are associated with worse outcomes. It's an excellent trending tool for both neurological deterioration and improvement. What we do is we observe them first, and then we try and stimulate and try and get some reactions. There are 3 categories that we check. We check motor function, brainstem, and level of consciousness. And in each of these 3 categories, there are 6 levels, which we add up to make a score. So it's quite complicated. You can download the sheets everywhere. But to keep things simple, I actually think of, all right, modified Glasgow Coma scale, MGCS. And so I look at the mentation, the gait, and the cranial nerves. So we check the level of mentation, and if they're obtunded, the level of obtundation. So often the nurses will laugh at me while I'm sort of waving my hands at the patient, yelling at them, because I want to know if they're responsive to visual, auditory, or painful stimuli. It's often difficult to assess walking in these patients. If it's safe to do so, try and get them up. Otherwise, at least check for voluntary motor function and reflexes for lower motor neuron disease. But the most important thing we want to look for is evidence of decerebrate posturing, opisthotonus, or tetraparesis from spinal disease. Now, there are really 2, and actually just 1 main cranial nerve that I use. That's checking their pupils for size, anisocoria, and response to light. So I'll often have the phone and the light source at the front end while everyone's doing everything else. Remember that the eyes can be normal, then as the brain gets worse, become myotic, and then just before death actually open up to become non-responsive and mydriatic. And the other cranial nerve we use is the vestibular ocular reflex, or physiological nystagmus, to help with trending. So we've got a patient. We've decided that dysfunction in the neurological system is a lot worse than our respiratory and cardiovascular systems. Then we need to consider that there might be primary CNS disease or a disease that's affecting the CNS markedly. So this is when we can start some neuroprotective mechanisms. And what we aim to do is maintain cerebral perfusion pressure. So cerebral perfusion pressure is your mean arterial pressure minus your intracranial pressure. And so when there's brain trauma, there's swelling of the brain, and the intracranial pressure can increase, which then reduces your perfusion pressure. So there are different tiers of neuroprotective mechanisms that we can start. It's always safest to start the first 2. What we want to do is avoid hypotension and avoid hypovolemia. So maintaining that blood pressure helps to maintain the cerebral perfusion pressure if our intracranial pressure is increased. Maintaining normal oxygen and avoiding hypercapnia. So hypercapnia leads to vasodilation and increases our intracranial pressure. I often get these patients on a spinal board and tilt the head up 30 degrees. What you don't want to do is put a towel under their neck and crimp their neck. That will occlude the jugulars and increase the pressures, and avoid jugular puncture and any interventions that might make them cough. Now, I tend to prefer hypertonic saline. I just think it has a much more profound effect, and also has the benefit of increasing intracranial pressure, increasing the intravascular volume, if I think that the patient needs some volume support. And of course, I'm going to follow with fluids and rehydrate them afterwards. If we think that there's spinal disease or spinal fracture, then getting them onto that spinal board is important. And remember that C-spine lesions can cause hypercapnia. Now, there are other tiers of therapy if these don't work. In people, they go on to an induced barbiturate coma, therapeutic hypothermia, aggressive hypocapnia to promote vasoconstriction and reduce the pressure, decompressive craniectomies, and lumbar CSF drainage as well. Of course, if these patients are seizuring, seizure management is really important. Now, although not really part of the major body systems, I still include a quick abdominal examination, because most of the time our patients present for abdominal emergencies. So I want to know if they are really painful from a septic peritonitis or if there's tympany from GDV. And if I've got the ultrasound out, then just doing a abdominal fluid score as well. Now, a crash plan is an additional approach to the emergency patient after stabilization. This helps to target management, particularly in trauma patients. And so if you're not sure what to do next, or you're just having a bad day. Now, in the major body systems assessment, we've actually already done A and crash. Then going down the list, it's important to assess the pelvis for fractures, luxations, and function of the urinary system and for fecal incontinence. Looking at the limbs for fractures and any big wounds. Arteries and veins for hemorrhage under the skin, and then any peripheral nerve function as well. Now look, it's really important to look after your patients, your owners in these situations. Most of them have never been through this before. I often tell people that we are going to, or we've just done, a quick assessment, and I try to use words that they understand, and this is usually words that they will have heard of on the news or on TV. So I let them know that, look, Fluffy's in a really critical condition. We need to do some starting tests just to tell me how sick she is, and then we can stabilize her. You know, this is life and death treatment right now. I won't know the full extent of the injuries or the underlying disease until she is stable. So they need to hang around in the car park or in the hospital for a few hours. And I let them know, look, I'm going to leave you, I'm going to hang up, but then I'm going to call you once she's more stable and I can step away from her. So she's the most important patient right now. And let them know that, look, new things will come up, but we will know more soon. So I'm very upfront with the owners at this point. So in conclusion, we look at the heart, the lungs, and the brain in our major body systems. We have parameters to assess perfusion, hypoxemia, and brain function. What this tells us is how sick the patient is, focuses our initial stabilization, and really shouldn't take more than 2 to 3 minutes. And this also then helps us triage all the other patients in the hospital. These are my references.